mature cystic sarcoma and I said benign, the differentiation between benign and malignant is a type of epithelium. If they're all mature, all type of epithelium from 3 germline mature, when I said mature means adult type, means benign. If you see any immature, means kind of primitive type of epithelium or material that normally you don't see in adult type, or they call it embryonal type of epithelium, those are immature. So difference, and those are malignant. So the making malignant versus benign or immature versus mature is type of the epithelium, type of the tissue. If there are a lot of mature adult type, it's benign. If you see any primitive or immature or embryonal type tissue, that's malignant. Remember, malignant one, you see it in the younger first 2 decades, and usually they are not cystic, they are solid and large, bulky. Cystic mature teratoma, reproductive age, benign. You just excise it, nothing, you don't need to do anything. If they rupture and if they produce portion, that can produce symptom, can produce pain, hemorrhage. Okay, that's that. Another name, as I said, is dermoisis. All these sebaceous glands, you can see hair follicle here, very much. So the next one, sex cholesterol. These are the group that have a very variable age range, and this is the one they call it fibroticoma. The area of the white is the collection of fibroblasts, so fibroma. The area of yellow, theca cells, so lots of time mixture to association. If they are large, more than 6 centimeters, sometimes they can be associated, 40% can be associated with ascites, and sometimes, but less than 5% can be ascites and right hydrothorax. They call it Meigs syndrome. So this is not metastasis, this is not a malignant ascites. This is just because of size and edema and pressure on the lymphatic drainage produce that ascites and hydrothorax. As soon as you take it out, those are disappears. So Meigs syndrome. Another one is association with Gordon, is nevoid basal cell carcinoma. So young patient come multiple basal cell carcinoma, skeletal deformity, and they have a mass in the ovary, is going to be a fibroticoma. And that's a Gordon. The last on the sex score, this is the one that tell you the patient comes post-menopausal bleeding and there is a mass in the uterus. Post-menopausal bleeding, mass in the ovary. That means this is a granulosal cell tumor. So remember when I said if the patient comes with the endometrial hyperplasia, endometrial cancer, one of the risk factors, unopposed estrogen, can be due to the tumor in the ovary, and the tumor is granulosal cell tumor. So granulosal cell tumor usually kind of solid, cystic, some areas cyst with the hemorrhage. These are the tumor that composed of granulosal cell producing lots of estrogen. That's the reason in this age group for this tumor is the postmenopausal. So patient comes with the abnormal bleeding, hyperplasia, and even endometrial carcinoma. The hallmark of these is this structure, these microfollicle, they call it Kahl-Exner bodies. So Kahl-Exner is this structure. Granulosal cell tumor, about 90–95% are benign. About 5 to 10% can have a malignant behavior, and they can recur even 20 years after the original incision. So we deal or we treat them all as a potentially malignant. So it's important to know. So they can be malignant and also estrogen. Last, metastasis. Most common tumor metastasized the GI tract, especially think about the stomach, Krukenberg. Appendix can metastasize to ovary. When it's a metastasis, bilateral enlargement. This was a Krukenberg. You can see signature cells. You can stain it with mucin carmine, and you can see positive staining. The last is breast. Think about the fibrocystic, one before the last. Fibrocystic change. Remember what is a fibrocystic change? It's the exaggerated hormonal response. Composed of these dilated duct, they call it Prudhomme cyst. They can be tender. Remember when it's a fibrocystic, is it lumpy, bumpy because of all these ducts that are dilated and tender, and then fibrosis in the background. What are the histologic features you see? You see a lesion material that like a dilated duct covered by these type of epithelium. They call it apocrine metaplasia that have an ability to produce lots of secretory material. And then you see fibrosis in the background. And I want to show you high magnification what is apocrine metaplasia. This is a normal ductal epithelium. So you can appreciate this is apocrine metaplasia, abundant eosinophilic cytoplasm, lots of mitochondria because it's producing lots of secretory material. That's the reason duct is dilated, become like a cyst. So cyst Acrometaplasia, fibrosis, none of these actually increase risk of future cancer. These are all non-proliferative. In contrast, this change, this is the one dot filled with all these cells. We call it ductal hyperplasia, and this is a usual ductal hyperplasia. This increased risk of future cancer about 1.5 to 2 times. You can see this is actually composed of two types of cells: luminal cells, ductal luminal cells, and myoepithelial cells. Next step after this is atypical ductal hyperplasia. Next step after that is the ductal carcinoma in situ. After that, invasive cancer. So at this level, increased risk of 1.5 to 2. There are other lesions. If you look at my lecture, that increased risk of cancer. They call it proliferative without ATP, or proliferative lesion without ATP. That increased risk of future cancer about 1.5 to 2. Another one is a sclerosing adenosis. Another one is a radial skull, and then this usual hyperplasia. But if they tell you atypical ductal hyperplasia or atypical hyperplasia, that increases risk of cancer 3 to 5. That's more important, more significant. This is a ductal carcinoma in situ. If you compare it with that hyperplasia, now the cells are kind of monotonous. They're all just, one type of cell. They have these spaces that, in compared to the previous picture, they're very orderly. You see it not only at the center, you see it at the periphery. If you look at the usual ductal hyperplasia, I showed you in the previous picture, the spaces were irregular. Here become very monotonous, very regular, kind of cookie cutter they call. So, and based on a grade of nucleus, they are low grade to high grade. So this is a low grade. Now, why grading important is because when it's a low grade, the risk of future invasive cancer or recurrence is about 10%. Well, when you're dealing with something like that, this is a still type, kind of ductal carcinoma in situ because basal membrane intact, and these are the cells all inside. However, if you compare this with the low grade one, low grade was kind of monotonous with cookie cut. This is all pleomorphic. There is a necrosis at the center, and usually have dystrophic calcification at the center. They call it comedotype with comedonecrosis. These are high-grade DCIS, and risk of future malignancy recurrence is 40% compared to 10%. So these are certainly more aggressive one and associated more risk of invasive cancer. By the way, invasive cancer arising from low-grade usually is low-grade invasive cancer. Invasive cancer arising from high-grade DCIS is a high-grade invasive cancer. So that's also changed. By the way, this DCIS comedonecrosis is important because this is what they can pick it up in mammogram. This kind of branching is things like, dystrophic calcification. This is what you need to know about breast cancer. Every time they show a lesion that have an irregular, abnormal density, and irregular margin, and this calcification that you see, they call it stipple calcification, which is a cluster with a different size and shape. This is a hallmark of the breast cancer. So two things. Mammogram shows abnormal calcification or calcification that are abnormal. That's telling you this we are dealing with the cancer, and the stipple is the buzzword. Also, abnormal density shows irregular, periphery. If I show you one picture, if you look at one picture, this picture, and I ask you what is the diagnosis of cancer, the reason it's a cancer because look at the periphery. This is the lesion. You can see this plastic reaction. That's the reason it has a kind of whitish color. But you look at the periphery, how irregular it is. So irregular margin is a characteristic of the breast cancer. Ductal carcinoma, invasive ductal carcinoma, composed of these ducts infiltrating, invading to the stroma. You can see another one. Now, one thing we know for fact help us to make a diagnosis of carcinoma is the loss of myoepithelial cells. So when you see myoepithelial cells lost, that's diagnostic. And this is another picture. You see this is our invasive ductal carcinoma. So kind of making it still ductal for the ductal structure. So that's important. Now, these are in the sentinel lymph node in our case, so you can appreciate these are all invasive ductal metastasized sentinel lymph node. Now, let's talk about the other region, well-defined, mobile mass in 20 to 30-year-olds, so younger usually. These are fibroadenoma. You can see it's very well circumscribed, and usually they have a kind of fair consistency. Remember, these are hormone positive, so they can actually during pregnancy enlarge. These are the fact that well circumscribed, you can shed a dot. You can see they're polyphasic, composed of dot and stroma. So these dots usually are kind of dilated, sometimes collapse. The stroma is a neoplastic component. Some people actually is on transplant, or some people on cyclosporine actually increase risk of fibroadenoma. Fibroadenoma sometimes can be a multiple. This is the one that comes with the bloody nipple discharge. It's the intraductal papilloma. Remember, we talked about it. That's a duct that dilated. That capillary structure is papilloma. You can appreciate that. So here is the fibrovascular core and papillary structure. Lobular. So in compared to ductal, lobular is a disease of the acini. So when you feel like these is a normal lobule composed of all these acini. Again, two layers of the cells. I want you to look at this one. All those acini are filled with these cells. Look at these cells. They are not very cohesive. They are discohesive because they lose encapsulation. Another important point, every time you see these lobular carcinoma, we call it lobular carcinoma in situ, means there's an increased risk of malignancy. Same breast or another breast, and that malignancy can be lobular or can be a ductal. This is actually shows in situ and invasive, and here you can see infiltrative lobular carcinoma, single 5, loss of encapsulation, so they are discohesive, single 5, that's very, very characteristic. So done with this case. Last case is molar pregnancy. We already talked about the different type. This was a complete mole, large uterus for gestational size, a very high HCG. You can see grape-like structure, normal, villi here. You can see in the mature term placenta nicely, and these are grape-like structure. If I ask you what are these grape-like structure, are dilated villi. And when you look at it, they are actually don't have any blood vessels and dilated. They usually kind of this hydrophic fluid, and they can be a space, but this is a proliferation around. See, cytotrophoblast, syncytiotrophoblasts, and this is an extensive proliferation all around. That's the reason this complete mole usually associated with a large amount of beta HCG. And syncytiotrophoblasts, these are the cells producing that beta HCG, and cytotrophoblast. Again, all around, surrounding this dilated, villi, this grape-like structure. This is choriocarcinoma. The difference between choriocarcinoma and molar pregnancy is this. In choriocarcinoma, you should not see any chorionic villi. You just see syncytiotrophoblasts, cytotrophoblast. This is a malignant tumor of the cytotrophoblast and syncytiotrophoblast. So remember the way the choriocarcinoma comes. If beta HCG after the DNC for molar pregnancy doesn't come down or goes up, it's choriocarcinoma. They usually come with the hemorrhage in the lung, metastasis in the brain, so it can be hemorrhage in the brain. Done. Okay, so that's ectopic pregnancy. So this is already talked about that. As soon as you see that, GC, chlamydia. So, any question? Good. So we're done. Now I see Dr. Ramadan outside. What time I have? Oh, okay. Should I do you want to continue, or should I let's see. So he's supposed to give you a review on NDME. So he will do that. Well, how was
let me actually stop this. So then, how was Dr.